Hi, this is Elliot Fishman, and welcome to our YouTube Live. Today is the 12th of January. I'd like to welcome everybody. Those of you who are concerned that I need a haircut, I would have to agree with you, though I did blow dry it today, so it looks kind of cool. But I will be getting a haircut on Monday, so please do not send any offers in to send me a couple scissors or some shears or something like that. Anyway, maybe the beard will go too. I don't think so. But hope everyone's doing well. It's hard to believe we're in the middle of January already. Hope everyone is doing well. Again, I also would um, like to reach out to our friends on the West Coast in California, LA, San Francisco, anywhere in between. Just the whole flooding. I mean, years of drought and now just super storms. It's weather these days, and I've said this before with global warming, that it's the excesses on the dry or on the wet side. Just this incredible. You saw the pictures probably on TV. I've seen a little bit. I don't usually watch TV, but just whether it's in Montecito or it's in LA, the trees falling down because of the dry and then the wet and the ground being soaked. Good news is it's going to help a little bit with the drought, but of course, what you need is a little bit of rain a lot of days in a row, not massive rain for a couple days, but it is what it is, and hope everybody is doing well. So that's one thing. Second thing, I was just reading, I was referred to the site, which is the American Cancer Society. They just have the 2023 update, and they mentioned, although it's not great, but it is great news in some sense, that the 5-year survival for pancreatic cancer now is 12%. Now you look and you say 12%, you got to be kidding me. You're happy about that? Well, if you go back a couple of years, it was 7% and then 8%. And it was getting close to double digits, but now 5-year survival is 12%. Early stages are in the 40 to 70% range, but all comers, 12%. Nothing to celebrate, but it's something to say we're making progress. So just to let you know, and hopefully we'll continue to make progress, whether it's AI, whether it's new chemotherapy, radiation therapy, combination therapy, surgical changes, you name it, early detection, liquid biopsy. I mean, everybody is looking at everything to see what we can do, but at least we are making progress. So with that, I think that's good news for everybody. Most of all, it's good news for our patients, right? Let me get that out of the way. Today's talk is on hematuria. Usually, when you speak about hematuria, you're thinking about renal tumors. And this talk will be everything but renal tumors. Now, with hematuria, we talk about macroscopic and microscopic. Macroscopic is the one you worry about. Those are the ones with, at any age, particularly as you get older, there's a higher propensity for malignancy. Microscopic, at any age, is more likely going to be okay, in the sense that it's less likely tumor, though it can be tumor. Macroscopic is you see the blood. Microscopic is on a dipstick. But of course, microscopic can still be tumor. So I don't want to play it down, but macroscopic is much worse. Okay, now hematuria could be due to many things. Now, one of the most common things we think about is a stone. A couple of comments. Flank pain, stones in warm climates, people are dehydrated, people have certain hereditary dispositions to stones. Stones can be anywhere from the renal pelvis to the ureter to the bladder. If you see a stone, you see hydro, you see stranding by the kidney, you're in great shape. Stone's hopefully going to pass. Under 6 millimeters, it's going to pass. Location, higher calcification, less likely to pass. But stone disease is a good cause for hematuria. Now, what if you don't see a stone and the patient was referred for hematuria and it was a rule-out stone from the ER setting? I said this before, I'll say it again. If you have a negative stone study in hematuria, you need to give contrast. Maybe not that moment, okay, fine, you're in the ER, discharge the patient, they need to be worked up. I am concerned that if you have a patient with hematuria and you don't find the stone, that you just assume it's nothing. It's not nothing. It's just you're not seeing a stone. It could be something else. It could be a tumor. So you need to go further, give IV contrast, exclude a tumor. Other things with hematuria. There's a range of crazy things or unusual things, from amyloid to sarcoidosis to lupus, many things. So, if you look at hematuria, the sheet is pages and pages long. In terms of us, tumor, stone, then you got to think infection, infarction. Now, infection, renal infection, CT is not the study of choice. CT is really good, but most patients with suspected infection need a urine culture and need antibiotics, and that's it. Typically, we say that CT is reserved for patients who don't respond to antibiotics or you're worrying about complications like abscess. But again, not every patient who comes in with flank pain are you thinking about pyelonephritis. You're thinking acute acute cholecystitis. You're thinking about liver disease. You're thinking about appendicitis, diverticulitis, and everything in between. So it becomes very important to recognize that there are many reasons. There are many things we can think about. So we don't often have the luxury of having the optimal study. Now, in terms of infarcts we see for a number of things: renal artery involvement, renal vein involvement. We can have it from tumors, but you can have it for aortic dissection. You can have it for vasculitis. You can have it from severe fibromuscular dysplasia. When you see infarcts in the kidney, most commonly it's embolic phenomena, often from a left atrial appendage clot. You see a wedge-shaped defect. It could be solitary, it could be a few, it could be multiple, it could be global. Global infarcts are more common when you have either injury to the renal artery, so the flow is entirely obstructed or stopped, versus embolic phenomena, which typically, although it can involve the main renal artery, typically are more common in branch vessels. So you'll have one or more segmental defects. Now, we do see renal infarcts more commonly in patients with endocarditis. You want to look at the heart when you're look at the left atrial appendage, see if there's a clot there that could be feeding it downward. So it's things you need to be thinking about, okay? That's really quite simple. Global infarction, renal artery injury, typically maybe a renal resection, adrenal resection, some type of surgery nearby where the renal artery is injured, though you can get embolic phenomena. You can get it from trauma. So the thing about infarcts, you can look at the arteries carefully and look for things. You could also see delayed function. You could see the fact that it's typically triangular because they're usually wedge-shaped, single or multiple. Infection can look very similar to infarction, and I think it's a challenge that sometimes people tend to make it seem like it's all that easy. It's all that easy when you have a good history, but you don't have a great history, it's not all that easy. Now, to me, infection, you're more likely to see secondary things like stranding around the kidney in the perirenal space. That low density zones can be multiple, can be diffuse, but they're not as sharply marginated. Both infarcts and infection can be unilateral or they can be bilateral. Infection is more irregular, not as sharply demarcated as infarction, so that can be very, very helpful. Again, with infarcts or infection, look at the vessels. Make sure you're not dealing with clot in the renal artery or clot in the renal vein. That would be very important. So those are things I'm thinking about. Again, infection, infarction, you may not see in non-contrast scans. Sometimes you could with infection when you get perirenal stranding or the kidneys enlarged or edematous, but you're going to miss a lot. I've said this before, unless you find the big stone causing hematuria, you better give IV contrast, exclude tumor, exclude infection, exclude infarction. So that becomes very, very important. We talk also about reading the images, look at the coronals very carefully, do MIPS for the vessels, make sure you're not missing small aneurysms. Polyarteritis nodosa comes to mind. Multiple small aneurysms. If you're looking for hematuria, the recommendation is multi-phase acquisition, arterial and venous, and delayed. You don't necessarily need to do the entire abdomen 3 times, but perhaps do an arterial to get the good vascular arterial map, do venous through the kidney, and then do delayed, depending on the patient's age, only through the kidney or down through the pelvis. Obviously, you can do non-contrast through Rosetta Stone first, kidney only. Again, if radiation wasn't an issue, everybody would get multi-phase. But again, we try to minimize the phases while maximizing the diagnosis. So you need to do things correctly. Now, what else can I tell you? I think those are the main things. We've gone about 10 minutes. I hope you guys like being on YouTube. We are putting a lot of effort into YouTube studios, building up our channel, and we hope everybody comes to visit us there. The lectures, the quizzes are all here as well. These discussions, I think, can be valuable. If you have any comments, I don't think top chat, I don't see anybody emailing me. It's interesting that on Facebook Live, more people feel comfortable, so they'll write their name, they'll ask questions. I think with YouTube Live being a little bit later in the game, most people don't use it or don't have it, or a combination of the two. But we are here on YouTube. We're looking forward to keep building the channel. So with that, I wish everybody a great day and see you later.